Hey folks, this is Brennan with the Blue Continent Podcast. Today I have the pleasure of speaking with Professor Dr. Bob Huish from Dalhousie University up in Halifax, Nova Scotia. He is an international development expert who specializes in global health, and we have a very interesting conversation for you. So enjoy.
Hey, Brendan.
Hey, Dr. Bob, how you doing?
Good, my friend. Good, good. Sorry, I was clicking on the wrong thing and it was being annoying.
Okay, well, I mean, I think we've all had that experience before, so don't think twice about it.
Good stuff. Well,
Yeah.
thanks for bringing me on board for this. This looks fun.
Totally, totally. So I'm recording now, and just wanted to say welcome to the podcast here. This is the Blue Continent Podcast. I started it relatively recently, but I was inspired by guys like you who have been kind of speaking about key issues. You've been doing it over several years now, so that's an achievement there. For anyone who doesn't know, or Professor Bob Hewish uh, well, you're both a doctor and a professor, aren't you?
I am.
Well, you look pretty young for being a doc, so you got it done.
Only in this light.
Only in this light. Hey, I got to get lighting like that. There you go. But anyway, you're the host of the Global Development Primer podcast, and that's fantastic. As a professor of international development studies at Dalhousie University, your latest edition of the primer, you were talking to a guy about a very knowledgeable expert about North Korea and the reports of Kim Jong-un and what health he was in and where he was, which was an interesting take. But typically, you're talking about global health concerns. That's
Mhm.
your expertise. You want to tell a bit about what you do every day?
Right. No, thanks, Brendan, for that. So here at Dalhousie, I teach a course on global health, and it's very timely now with the pandemic. It's something, today where there's no bystanders. We're all in some way affected by the pandemic, and then have a concern with global health as a result of it. But what the class looks at is not just why pandemics occur or why health calamities occur, but what are the reasons why they occur and how they impact people in different ways. And it's research that looks not just at illness and disease and how it travels around the world, but really at that concept of what is health. And that's something that even in medical schools there's a struggle with. And I argue this quite a bit in my class, that when you go into a medical program, one of the first books that they'll give you will define health usually as the absence of disease. And you can look this up right now on your dictionary on your iPhone. And the common definition of health is just being free from illness.
I've heard
But
that.
it's a weird way to define something that is so intimate and important to everyone's life. If you look up the definition of an apple, it doesn't say not an orange. And yet we
Right.
define health by something for which it is not.
What is not.
So
So
a
I
lot,
guess
yeah.
disease, the definition of disease is just as relevant as anything.
Sure. Yeah, exactly. And in many cases, when you look at global health, it's not just about catching a disease, catching an illness, and finding a cure. It's a really complicated relationship between people and place and the social, cultural, economic, and environmental conditions in which they live in. It's why we're already seeing some research from the pandemic, the COVID-19 outbreak, about how there are racial, there are economic, there are regional challenges that will allow this virus to manifest over some groups of people, while others will be relatively safe. So
I
my
just
work
want to interject
looks at
real
those
quick.
inequalities.
I'm just
Hmm.
going to point out to any listeners who want to pursue that specifically. The daily podcast from the New York Times just yesterday really examined
Hmm.
why the African American community is being hit so hard in like three different ways. So anyway, didn't mean to interrupt your flow on that.
No, no, please. No, so that's basically the idea, is that the teaching that I do tries to take students through case studies and examples of this relationship between illness and health and place and power and politics. And coming away from that, we've got students who will go into social sciences and policy. We've got students who go into medicine. And the idea is to see how these health issues are not just about contracting a disease, how they are really the product of our society. And inequality is always at the heart of it. One of the things I do in my own research is look at how countries take care of each other. So I've been working with Cuban health workers for over a decade now
Hmm.
to figure out what their programs are and how they respond to these global challenges.
Yeah, no, that sounds fantastic to examine, and I don't want to overstep, but you shared with me that you were writing a piece on the Cuba's
Hmm.
response to COVID-19. Are you able to tease that at all?
Yeah, for sure. One of the things that I'm keeping my eye on right now with Cuba's response is getting back to that idea about what is health. You were seeing so many countries respond to the pandemic in their own unique ways, and there's a lot of comparison. Okay, this country's done this, and Sweden's doing this, and Taiwan had this
Mm,
initiative.
yeah.
It's more complicated than just moving chess pieces around a board. It's
Mm,
to look at how effective a response is to a pandemic. We sort of have to get at what are the underlying ethical
yeah.
foundations of a health system. So in Cuba, for example, their health system has been founded on the concept of building personal and public health. Those are the two goals.
Mm,
And health defined in a wide sense about a complete state of physical and mental, emotional well being. So their system responds to it, and it allows them to put a lot of health workers in the front line before emergencies kick off. So you've got the classic cases of doctors and nurses living in the neighborhoods, polyclinics being available within 2.5 kilometers of any urban house or 10 kilometers of any rural house. And then also a long-standing campaign of sending doctors and nurses, psychiatrists, pediatricians to other countries who are in need. So
right.
when that's combined and you've got a 60-year legacy of a country that's dedicated resources
Hmm.
to promoting and creating health, they respond very well in times of pandemics. Uh, Meanwhile, on the other hand, you could look at the state of New Jersey, where the pandemic has been, one of the epicenters in the world has been in New Jersey. And the US system, by all rights, by all the technology and advancements and
Hmm.
the number of health workers that are there, it's a system that is not unified and ultimately one that tries to keep people out of it. It's one that doesn't encourage usage. So when you have these emergencies kick off, this is what you see. You see inequalities, you see lack of resources, you see uncoordinated efforts, you see people being turned away, others being taken in, and this sort of
Yeah.
discombobulation is what we're going to see result during the pandemic in the States.
If you had to use a short phrase to characterize the American response, the U.S. response to the crisis, what would you say?
I would say disaster would be the number one. This is something where there's a very real health emergency that has been either not taken seriously by the top leadership
Mm,
or been taken in a very uncoordinated manner that's left a lot of people forming their own practices, their own policies, and if anything, furthering a lot of mistrust with governments at the state or the national level. The countries that have done well on this are the ones where people tend to trust what their leadership in public office is saying. And also when orders are put forward, that individuals are able to comfortably compensate with it.
mm,
Countries like India that put a moratorium on all travel and sheltering in place in India, there's no social support for people to do that. So
mm.
that's really, really risky. When people are told to stay home in South Korea, there's
Yeah.
resources there to make that more comfortable.
Yeah, I guess what you're saying is this is a direct relationship between but people's trust in their government institutions and not having trust, and that trust is actually built on being able to successfully come out of crises. It's so to speak, to the extent that a crisis exists in Denmark, right?
Mhm.
Yeah.
It's something. I mean, most societies can respond to crisis if they value what that crisis is about,
Mm,
and we've seen so many alliances and partnerships and cooperations around the world be formed on security threats. Here's this enemy over here. Maybe it's a nation, maybe it's a
Yeah.
terrorist group. Let's get together and go at that with full resources.
Right.
But in terms of pivoting away from security threats to problem-based threats, that's where I think every country's lacking in quite
It's
a bit, is
easy
how to
when there's a
coordinate.
literal missile that's pointed at you, right? If you could
Mhm.
get people to conceive of a virus, like when it's on the other
Yep.
side of the world before it really starts to impact you, as a figurative missile, right? Then you could maybe
Mhm.
get some alliance on that.
It's a great point. You mentioned earlier on GDP, we interviewed Greg Scarletto, who's an expert on North Korea. And I've done some work on North Korea, and this is actually where it connects back, that
Hmm.
for decades now, you've had a health and human rights crisis in North Korea. People kind of pay attention to it. It gets complicated, gets ignored. But then the minute a missile pops up, boom, everybody is on it. There's regional strategies, there's sanctions, there's tough talk. The whole
Right.
world stops for something like that. And again, that's because it's very digestible to understand what that threat is. It's very visible, but also a lot of our international apparatus is designed to respond to it. Where a
Yeah.
collaborative pandemic, we
Mhm.
just haven't had the toolkit.
Well, specifically on North Korea, I'm 38 years old. My whole life, it seems like every time North Korea feels nobody's talking about them, they would just go send up another missile, right? And
Yeah.
then they get all the attention and everybody talks and then they engage with them and, oh, what can we do? And probably at that point, China gives them something that we don't even hear about,
Mhm.
right? But this is
It's
very,
it's exactly.
yeah.
It's that's exactly been the case there, that you've got a country that is a great example of one that does not take care of its own people. It's one where about half the country are actually classified as hostile against the regime. And you'll watch the news items very carefully. It goes from alarmingly scary missiles and weapons and chemical warfare projects and cyber hacking to hilarious, right? And it's this mix of messages that, is Kim Jong-un gone? Is he missing? Have they discovered a unicorn den? That was a real news story in 2015.
Really?
Uh, you know, yeah, and it's designed in this way to balance humor with shock. And again, it doesn't really get to the problem of what that country's about, or the human rights crisis there.
So in a practical way, like what has COVID-19 revealed more broadly about the state of global health systems and the role of the WHO in a
Mhm.
future that, hopefully what needs to happen?
Right. So the thing is, with pandemic planning, which the WHO has provided resources to every member country in the world, that starts when a pandemic has kicked off. And that means, okay, this is on the edge, or there's an epidemic in this region here. Here's how we buckle down. But basically, the playbooks that are in existence are ones that deal with the emergency after it's happened. There's
Mm,
been very little about trying to prevent one from happening in a more holistic sense, and just simply looking at how, again, there's no bystanders to this. Everybody is a part of this pandemic, and look at what the principal response has been by most authorities in the world. It's
mm.
been stay home, shelter in place, and don't go near people. These are ancient methods of
Right?
public health that they go back, like quarantines and isolation. They go back to the book of Leviticus.
Yeah.
And you think about the sort of stigma that arises from isolation or labeling one group or community as being diseased. Think about leprosy, you think about the plague. All of these things are coming out of incredibly ancient public health methods, and as a result, they have very serious consequences: economic consequences, social consequences. We are going to be unpacking the impact of COVID-19 for quite some time. So what the World Health Organization, people sort of look to it as being this international body of answers. And really, it's actually a very fragile organization within the United Nations complex. It's originally was started as the League of Nations malaria uh,
Huh.
campaign and infectious disease campaigns in Africa, that was started just around World War I. And the idea was from there is that as more development was going into South America, Africa, and Asia, there was concern about the spread of diseases. Many workers were starting to perish on a lot of these railway and projects or building of canals. And the concern initially by League of Nations wasn't so much that yellow fever and cholera and malaria would make its way to Europe, but that it would make its way between the colonies. So Britain was really panicked about putting a rail line through Tanzania or Kenya, and then suddenly have those workers go back to India and spread the disease in that colony there. So from the onset, the League of Nations was about disease. In the 1930s, with a lot of influence from the Soviet Union, and after their experience with famine in the 1930s, there was a strong movement to move it more towards the concept of health and public health. There were models that came out from the Soviet Union in 1933, 1934-ish, the Shemyshenko model, which looked at health promotion and disease prevention, trying to keep people in a good state of health before a crisis took place. That really influenced the development of this League of Nations health body. There were many conferences that discussed about global health policy. World War II hit, and then after World War II, the enthusiasm went straight towards penicillin and went just at vaccines, penicillin, and rightly, rightly so. I mean, World War II was the only military combat, military theater at that point in history where most people actually died of their wounds as opposed to infections. So penicillin was a miracle drug. From there, the United Nations formed the World Health Organization in 1947, where they had this very holistic claim about what health was, the state of complete physical and mental well-being. But then they came up with two major campaigns, the campaign against smallpox and the campaign against malaria. And both were very what we call downstream. They were about getting medicine to people. They were about trying to deal with the disease, not the health of people itself. Smallpox, victory. Malaria, still working on it. And that shattered a lot of confidence of the WHO by the 1960s. And the US started to withdraw funds from the main operating budgets from WHO during that time. As a result, it went into two different batches. There's your main operating budget, and then there's your emergency reserve budget. So the emergency reserve is basically what the WHO runs on today. It's something that, in terms of its funding, can only deal with diseases that are becoming emergencies. In terms of its long-term coordination and planning to prevent, very, very limited capacity.
Is it scripted to only deal with those types of issues, or is there a reason why it can't expand and become more useful and tactile for the rest?
Right. So it's sort of harnessed by what donor nations give to it. And there's the regular operating budget by the WHO and the emergency reserve budget. Most of the funding that goes into the WHO today is that emergency reserve. So if it's
only
Ebola,
limited
if
by
it's
funding, basically.
Exactly. And so if donors are saying we want to fund Ebola response, but yet there is maternal and prenatal health challenges within the same region, that might not get any funding. Or if it's research about knowing how access to good work, minimum income, safe housing impacts health, there's no budget for that. There's no program for it. Nothing's going to happen. And I'd say since the 1990s, it has been very much about responding to specific diseases. You see the role of Gates, you see the role of the Global Fund that target the disease rather than the total health of a population.
I was going to say, because a lot of the advice, or at least the narrative that you were giving at the beginning, was about the underlying health of any population is how you determine the outcome when they go through something like this. Their concept of health, which was your first point, was the definition of health. And I was wondering, if we're talking about the role of the WHO, with the US, saying that they're going to withdraw, support financially, and China already stepped up and went, here's an easy win for us. Here's an opportunity for us to one, influence the future of the WHO, where it's going, but mostly get a whole lot of positive PR as America gets the ire of the global community by saying that we're going to withdraw support for WHO in the middle of the greatest pandemic that anyone's alive has seen. You know,
Yeah.
that's incredible.
I mean, this is something where I think a lot of the history of international development and global health has been with the U.S. at center stage, and there are certain approaches that the U.S. has always brought to the table. About the Harry Truman speech in the 1940s about scientific advancements, economic development. That's the key to it, and those can work in wartime economies. Simply put, there can be a lot of change and development, and even improvement in people's life after a conflict if the economy is structured in a way to go after those quality of life issues, again, employment, housing, technology access. But when viruses come about like this, they the US system just doesn't respond well to it. And again, that may be a very deep reflection about how there is no universal health system in the US, where most other countries have some form of it.
Yeah.
I mean, even to look at Ghana, they have universal health care, limited, lots of issues with access, but there's the concept that there is a universal system in place. Right. Same with Vietnam. And these are two very poor countries that are doing incredibly well within the pandemic. Yeah. So if a country doesn't value health for itself, it's not going to value it for anyone else.
That's very true. So here's a question then. I mean, you've been someone who studies global health systems across the planet, right? So
pretty much.
Here's my question is, how, of course I'm talking to you from Maine, and you're actually a stone's throw over there in Halifax, right?
That's right.
How can we use this as a moment as United States citizens to demand better and say, look, we look around the whole world and Ghana kicked the crap out of us in their virus response, right? Like Vietnam, a country that we destroyed like half a century ago. How can we demand a better system and say this is unacceptable?
Exactly. I think there's two jumps. People have to value what is being proposed for change. And so what I mean by that is that it's hard to invest political momentum or personal enthusiasm in something in which you don't know what the outcome is. It's why a lot of climate change activism, a lot of alternative growth beyond GDP growth is so hard to get going into policy, because people are like, we're not used to this. We don't know what it's going to look like on the other end. We don't want change. It's a natural reaction. The thing with the pandemic is that numbers in the States continue to grow very steeply. There's loosening of ordinances across the country right now. No one is going to not have a story about either being infected by the virus or knowing someone who's affected by the virus.
A shared experience.
100% universal. Everyone is going to have an experience with this. So that's the moment to realize what I think are two things. And the first is that there are countries around the world that have created prosperity and growth and betterment by investing in health, not by chasing around enemies, or drumming up fake security threats or proposed security threats, but to actually look at real health problems. And countries like Cuba, some of the Scandinavian countries, by having systems in place that deal with health itself, the economy grows, the population is more confident, resilient, et cetera, et cetera. So to realize that there are models that work in that way. The second thing to realize is that American exceptionalism is not going to be the cure for COVID-19. You can't just ignore it. And you can't just ignore it by going to a public rally with weapons and no face masks, as we saw in Michigan. This is something that the exceptionalism that has been very much bestowed within American politics for the last 30, 40 years, this virus doesn't care about that at all. And this is what we're going to see come out of it.
Yeah, I have to say, I agree with that. Unfortunately, it seems like a tough lesson, but I can't remember the last time that America, with this exceptionalist thinking, has succeeded in solving a problem, you know? And
Right.
we didn't learn from Sandy Hook. We didn't get serious about gun control. We didn't get serious about climate change after Katrina. I guess
Nope.
9/11 you know, we attacked the wrong country, but we did we made airports safer. I would say we made
Yep.
airplanes and air travel safer. So that's something. Um,
Hmm.
I don't know.
It's 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 a it's one of the experiences that you can look at carefully to see just sort of the perverseness of this. Again, comes back to Cuba. So Cuba still is a lingering threat in the minds of Washington.
Conservative Americans.
Yeah, and it's really political malarkey. I mean, it's focusing on this Cold War 1962
Mhm.
image of Fidel Castro with his thumb on the
Yeah.
button. And yes, those days in October were nearly the end of all of us. And you look
Yeah.
at the memoirs on all sides, and
Yeah.
everyone was wrong.
Yes.
But the thing is, they've moved on from that quite a bit, and there's quite a bit of literature out there that shows that the U.S. military is actually pretty content that you have a stable government with a large-sized military
Yeah.
in the Caribbean, which is Cuba. There's a lot of regional stability in the
Right.
Caribbean thanks to Cuba. Um, so the politicians get going on this, and that memory of the Cold War panic still allows the Washington to keep one of the most restrictive embargoes in
Mm.
human history on this country. There are 6 separate clauses that are put onto Cuba, 2 of which target specifically food and medicine. So at a time when Cuba is saying, hey, we can send doctors to Italy, we can send them to France and
Yeah.
throughout the Caribbean and into Brazil
Yeah.
if you need it again, there you've got Washington actively encouraging other countries to not receive Cuban health workers.
Right.
Now, what I can't get past in that is here's a country that's willing to help others, and there's a White House that's also prepared to make the effort to spend those calories to try to defame a country
Right.
trying to help another one,
Right.
and that is beyond perversion.
Well, that's because you're Canadian, you know? You gotta you gotta,
Yeah, I guess
uh,
so. There's that.
you know, you can't wrap your head around that because it's a very American thing, I gotta say. I mean, I remember there were some hurricanes that struck the American East Coast, and Cuba offered to give them oil, right? Like they like
Mhm.
winter heating oil or something, and
Yep,
we're like, nope, sorry, we won't take any help from you guys because 60
that's right.
years ago we didn't like Castro, you know? Mm.
Exactly. It was 2005 with Katrina, Hurricane Katrina, and same thing. There was a group of medical students from the U.S. who were actually studying in Cuba that said, "Hey, we want to go and help." The call went through the diplomatic channels, and
Yeah,
and George Bush was like, "No,"
yeah,
and just
yeah.
that was
Same
it.
thing
No,
happened.
we don't want thousands of doctors and tons of medicine.
No, but I can.
This
You got
doesn't
to
happen.
imagine, as you were saying, that the American military apparatus is much more comfortable having, you know, whatever relationship we have with Cuba, having
Mm,
a strong government there in place versus, say, what you've got in Honduras or El Salvador,
yeah.
right?
Oh yeah. I mean, I think it's very important when talking about countries like Cuba that you realize it's a political issue with the executive side.
Yeah,
The U.S. military, as with many militaries, it can be very important during pandemics. They're very good at transporting goods and people, and also coordination.
mm,
And there's a lot of coordination and
mm,
respect, I'd say, between Cuban and American military forces. We just don't see it. That's not making headlines.
yeah,
But there's just, the U.S. has the Guantanamo Bay base there. It's on Cuban soil.
mm.
But in terms of regional security, Cuba's a big player, and I think, yeah, the U.S. is very appreciative of that.
Have you followed what the COVID response in Venezuela has been like? I was listening to some BBC reports where they're talking about how doctors, like, they don't have a very high caseload right now, but
Mm-hmm.
the government or the country itself right now is so screwed up that the doctors can't even get to work because there's no
Hmm.
gasoline in the
Yep.
country with like the most oil reserves in the world, which they can't refine apparently. You know, these
Yep.
guys, they can't even get gas. You have to pay somebody to sit in your car for like a whole day to fill
Oh
up
yeah.
a gas tank or something. It's such a disaster.
No, Venezuela is a train wreck in many regards. And why is there such low COVID-19 cases there? We don't know. I can make two strong guesses. First off, is that no one's going into Venezuela willingly.
Yeah,
I'm sure there's still people who are there for whatever business they might have, but there's been 4 million migrants that have come out of Venezuela over the last 2 years. That's enormous. It's an outflow country going in, and now there's concern that a lot of the migrants from Venezuela who have landed in Colombia are now being forced to return
yeah,
back into country. So that's one issue. The second issue is that Venezuela, despite working with Cuba very closely between 2001 and 2008, was actually really on track, trying to very aggressively create a universal healthcare system that was supposed to be a model for the Americas.
hmm,
But they jumped it too quick. And there's a long, convoluted story we could talk about of Hugo Chavez taking control of
yeah,
the oil company and the crashing of the price there, and then
mm,
massive debt and corruption going from there. Long
right,
story short, is they have a very dysfunctional health system where antibiotics, the basic cleaners, aren't even available.
mm,
So to do any sort of accurate testing on COVID-19 in Venezuela is going to be
yeah,
difficult to impossible. As you said, there's gasoline shortages, there's money short, there's everything
yeah,
shortages in
yeah.
that system. So dysfunctional systems just can't really record data very well as well.
That makes complete sense. Um,
Yeah.
well, how can people get more information? They can follow up on your work here at the GDP
Sure.
podcast, and tell about the courses you're teaching right now if anyone's interested in that.
Yeah. Yeah, please do tune into to Global Development Primer. It's a podcast that covers global health issues, but again, we bring in people who want to share anything to do with global health or global development as well. A lot of these podcasts actually go into a class that I offer at Dalhousie, and what that class is an online introduction to development class. We started it before the pandemic, and it's all podcasts. So students will tune in, they can listen on their phone, listen on their computer, and then when the podcast is finished, a quiz pops up. They have to pass the quiz, at least 66%, and then the next podcast opens, and the course just kind of keeps going on and on like that.
That's fun.
Uh, it's great because it's a lot of the online learning before the pandemic was so intense. Like you'd have these very busy screens, and there'd be the professor there with a camera shooting up their nose, and a fancy PowerPoints and a chat room and something else going on. Uh, Now with up to 15 or 20 hours a week of screen time that most university students can expect,
Yeah,
just to chill out for 30, 40 minutes, headphones, audio only,
yeah,
we hope will provide some more of a relaxing form of engagement. But the idea is that this class is available from around the world. We've got 300 students enrolled this summer. We're rolling it out again in the fall for up to another 250. Students from other universities can contact us and see if they can get it as a transfer credit. Not a
nice.
problem. But the idea behind that course and the other courses that I'm teaching on global health is trying to just get away from the discussion about chasing diseases, to really look at what is health, how do we take care of each other, is it at all possible for people and governments to work together on common problems rather than just focusing on supposed enemies.
I think that's a great point, and I really appreciate you joining me here, Dr. Bob, and talking about these really fundamental issues that people are talking about everywhere now.
Oh,
And
it's great to be here, Brandon. Thanks so much. Congratulations on setting this up. It's a vital tool in this day and age. So well done, you.
excellent. Thanks, sir. Take it easy.
Okay, you take care now. Bye bye.